Neat. That's put my our organization does work in three primary areas. First is through our programs and technical assistance, where we provide assistance to our health center members as well as to our other national, local, state partners. We also have a research and data team that focuses on those activities for Asian Americans, Native Hawaiians, and Pacific Islanders. And in my role, policy and advocacy, it really is focused on direct advocacy with Congress and the administration, as well as coordinating our national coalitions of advocates, which is why I'm here today. So the way that AAPCHO structures our agenda is really in these five buckets. I'm not going to name all of them, but really it's how are we supporting community health centers? How are we getting data on behalf of our communities? How are we promoting immigrant health? How are we promoting broader AA and NHPI health in the context of the broader health advocacy arena? And then what are the many other pieces of the national healthcare landscape? And part of this is our focus on three disease-specific areas: hepatitis B, which is our work with Hep B United and the foundation, diabetes, and tuberculosis, where we lead up a TB Elimination Alliance. I saw Chibo is on here. So hi, Chibo. Glad that you can join here. What I wanted to do is just provide some context on a couple of critical things that APCHO has been engaged in, and how is it that we're trying to address some of the threats that we've seen over the last 10 months or so. First, I'm going to start with the administration. You may have heard, and I apologize if this gets a little um, policy wonky, but a couple of months ago, the Department of Health and Human Services announced or put out a notice in the Federal Register that it was going to reinterpret how the department was going to consider what a federal public benefit is. And that they would rescind previous interpretations of this. The reason why they are doing this is they're trying to make it more difficult for many immigrant communities to access federal public benefits. If you go back to the 1996 Personal Responsibility and Work Opportunity Reconciliation Act, Peoria Welfare Reform back in 1996, it listed several immigrant categories that would be eligible for federal public benefits. And if you were not on that immigrant category list, then you were ineligible for those benefits. Part of that is that if you were on the category list and the federal program was on the federal public benefit list, you could access that program. Otherwise, you could not. For a very long time, community health centers were excluded from the definition of federal public benefits because of the way our funding structures have occurred. And that allowed health centers to care, as the law requires, for anyone in their service area, regardless of their ability to pay, which also includes regardless of immigration status. If there is a redefinition of this, health centers may no longer be able to exercise that flexibility in the patients that they're served. APCHO and many of our health center partners joined efforts to oppose this notice. There's also been several legal challenges to this, and as of today, this notice is on hold. There's been a nationwide injunction in two district courts that are placing this on hold. So it's something that we're continuing to monitor right now, but it hasn't gone into effect, and I anticipate that these legal challenge will be ongoing. I'll share the slides later. This is just some of the other programs that are being considered to be reclassified as a federal public benefit that are currently excluded. The second piece that I did want to share an update for is on the president's executive order that designated English as the official language. What the executive order did is try to make, or at least for the executive branch, try to insinuate that English is the only language that can be promoted within federal departments. as well as rescinding a previous executive order that's been in place since the Clinton administration, Executive Order 13166, that really provided the stipulations on how federal agencies would outreach to individuals with limited English proficiencies. That EO has been rescinded by President Trump. And there have been steps that several of the federal agencies have been making to comply with the Trump executive order. If you go into several of the agencies, their language access plans have been pulled down, and their civil right enforcement offices are no longer focusing um, on activities to try to support language access proficiency within their agencies. The Department of Justice's guidance has also been rescinded, which provided stipulations for the federal departments on how they would comply with the previous executive order. What does this mean in a practical setting for healthcare programs, though, is a little bit mixed. And it really one thing that I want to emphasize is while the federal departments may not be prioritizing language access proficiency assistance, the entities engaged in healthcare are still required to provide language assistance to patients and to the individuals that they serve. So if you go to a doctor, they are still required to provide language access assistance. Health insurers and other payers are also required to provide language access assistance, and that's because they're covered by Title VI of the Civil Rights Act, as well as Section 1557 of the Affordable Care Act, both of which the underlying statutes and the guidance that are implementing them continue to be enforced. So again, like while there's a deprioritization of language access proficiency in HHS and across federal health programs, excuse me, and across the federal health agencies, those engaged in healthcare in the US are still required to provide that. Something that I also want to note is that there have been several activities within the states to try to improve language access. I know that in California, there's a language access bill that is moving forward in the legislature, and there's been a lot of advocacy there. There are other provisions within various states, both existing and ongoing, that that with it, depending on what state you live in, there may be specific state or local requirements regarding language access. And then, so those are two overarching things. One thing that I would be remiss though is we know that we're in a pretty difficult environment within healthcare right now. And I just want to note some of the challenges that we're facing, especially given the enactment of HR 1, the One Big Beautiful Bill Act, OBA, however you want to name it here. And I do just want to say a couple of things around this. First is the exceptional impact this is going to have to many families across the country. About 16 million people are estimated to lose their health insurance coverage. There's significant restrictions on immigrant access to healthcare programs, and it is the largest retraction of federal support for healthcare in this country's history. And it is going to have a catastrophic impact, not just to the 16 million individuals who would become uninsured, but to healthcare providers, to other patients who will just see their healthcare costs rise as a result of this bill. What does it mean for Asian, Native Hawaiian, and Pacific Islander communities? Is about 4.5 million individuals of the 26 million people in our community rely on Medicaid, and about $1 trillion in cuts to the Medicaid program is over the next 10 years is gonna really harm the ability of individuals who rely on Medicaid to get the care they need. 2.7 million individuals within the AN and HPI community are Medicare beneficiaries, and about 1.5 million receive care through the marketplace. And that of that 1.5 million, we know that a significant number of those individuals will see their healthcare costs rise because Congress has yet to extend the premium tax credits, the enhanced premium tax credits that are due to expire at the end of the year, which will lead to nearly doubling of many individuals' health insurance premiums. And the last piece, Frank, I'm sorry, I know I'm a little over time, is the where are we right now? The government shutdown is having a catastrophic impact to community health centers and patients who rely on health centers to receive their care. It's about 34 million individuals in this country, about 1 in 9 people who reside in the US. And this is in two critical pieces. 100% of health center funding is currently tied up in the standstill between Republicans and Democrats. FY26 appropriations, which is about 30% of our funding, and health centers need to be reauthorized. Also, our healthcare programs are significantly impacted by the standstill. They're expected to be significant cuts to health workforce programs if they do get to fiscal year 2026 appropriations, and then two critical programs for health centers, the National Health Service Corps and Teaching Health Centers graduate medical education programs also need to be reauthorized, and they're currently expired. They expired at the end of September of this year. So, where are we? I think that's the end of that. I stopped sharing. So, it's a difficult environment. I want to pass it over to you, Frank, but just interested in having a conversation on how is it that we can move forward, where is it that we can go from here, and how is it that we can work together to ensure that, we're all getting the care that we need, and that, we're working in concert with each other to advance healthcare in the US. Thank you.
Thank you, Adam. Really appreciate you coming on and taking the time. When we were putting together this mini summit and thinking about what should be touched on around policy, we at the foundation very much look at hepatitis B policy and tried not to look at it in a silo, but there has been a lot around hepatitis B policy this year, and so we haven't necessarily been able to stay as on top of things like English as the first language and other changes to how clinics are able to be accessed. And those changes really do impact the communities we're serving and across the disease space. And so really glad you were able to come on and highlight some of these other attacks that are occurring that are impacting our community. I am going to keep it pretty B focused, and I will be going quick because I can, and we might catch up some of our time. But if you have questions, please do submit them into the chat. I don't want to skip Q&A if there are questions, and I'm always happy to answer them. So there are a lot of different ways we could slice what has happened so far in 2025 and what we've been focused on at the foundation when it comes to hepatitis policy. But I find that potentially the best way to slice it is proactive versus reactive. So there are things that we, going into the year, set out to do, and we have continued to work to do that. And then there are things that at the beginning of the year we hadn't happened yet, and now they have, and we had to respond. So I'm going to start with sort of the good news first, if you want to call it that, the things that we were proactive about. So the foundation ran around the hill back in February to start having conversations about our report language. Report language is text that is submitted by Congress as part of their appropriations bills that help really define how some of that appropriations money can be made. It is like a bit of the red ink or red tape of government, but it's really beneficial to advocates like all of us because Congress is saying that CDC and others get to spend money, and we can ask Congress to say, oh, and be sure you spend this money equitably. Make sure you spend this money after you do a report on where this money would be best spent. You could really ask some of those different questions. So we submitted, even outside of any of the attacks that were happening, submitted report language really looking to maintain the perinatal prevention program, to really keep tackling liver cancer and its causes, to support vaccines for children, because we understood and understand how important that birth dose is, as well as going and maintaining the viral hepatitis labs. It also included research, cancer research at NIH. So these were just specific pieces of language that were like, hey, liver cancer, hepatitis B needs to be focused on in this way at these agencies using this funding. We also included work to include liver cancer and hepatitis B in the peer-reviewed cancer and medical research programs. These are DoD-led efforts looking into health research. They are extremely beneficial, and the ask is really just that hepatitis B and liver cancer may be maintained within those programs because it is something we want to ensure folks, both members of the DoD are protected with, but also that information that the DoD learns through that research does go and make its way to the public and can be beneficial for treatment and other research down the road. We supported the funding asks to combat viral hepatitis as well as opioid-related infectious diseases. We have requested increases in those funding lines as well as funding lines at NIH year over year. But we do spend time within our meetings really driving home the point that public health is under-resourced in this country and that federal investment can go a long way, especially in places like hepatitis B, because we are so under-resourced that even a little scrap is more than what we're getting in many cases. And so that little scrap can have an outsized impact, unlike some of the bigger, more well-resourced areas that are kind of some of the low-hanging fruit of getting dollars to action have been realized. We have also, in this year, really been supportive of point of care testing for hepatitis B. This is something that we have pushed for a long time, that the government over the last several years has been making inroads in. Right now, through the RADx ITAP program, which is a joint partnership between the FDA and NIH, they are in the process of distributing point of care tests and analyzing the effectiveness and efficacy and safety profile of those diagnostics. And our hope is that they will be approved sometime in the next year. This is another thing that the administration change has impacted, just not so much this particular program because of what it is, but this program has to exist within other efforts within NIH and FDA, and those folks who did contracting at those organizations and agencies have been some of them were let go. We're now in a lot of folks are furloughed and have been for a month. So these delays really do have downstream impact and has impacted this point of care testing plan. And we have been supportive of the Hep C elimination plan insofar as we've been asked about it. It really is a Hep C plan. We only have 1/500th of that money kind of earmarked for hepatitis B. But we do want to see it get passed because all of these folks who would be tested for Hep C are also going to get tested for Hep B. And as you'll see on the next slide, we're actually potentially going to lose some of our other entries to testing. And so it'll be important to have these ones covered. Reactive. All right, so these are the things that we've had to sort of drop everything and go and sprint into action. This is kind of a depressing list, so please practice some self-care after this session. The viral hepatitis laboratories were part of the April 1st RIFs. Thankfully, after about a month, those individuals were brought back. But over that month, we really did spend time highlighting to Congress and the administration the terrible impact that shutting down that branch was going to have. This really was the labs that all 50 states could send their tests to, get responses back for free, like at no cost to the state. And so we are glad that they're back. But again, even that 1 month disruption was really an unnecessary one for public health infrastructure and for those folks who were working in that lab. We have been opposed to some of the proposed changes to CDC infectious disease funding. Right now, the White House, the House, and the Senate have three very different plans for FY26. The White House's plan very much includes viral hepatitis in a block granting of HIV or of TB and STI and moves a bunch of HIV programs over to a new administration. The Senate bill does almost none of that, and in fact was pretty bipartisan and fairly supportive of our efforts. And then in the House, viral hepatitis was in fact not only left alone, but was given a slight increase in funds at the request of the Senate. And so viral hepatitis is not included in the block granting, but STIs and TB are in the House plan, as and HIV programs would be moved elsewhere. We are concerned about the downstream impacts of those changes on HEP, in that TB programs do look at other infectious diseases. STI programs also will do blood draws and other testing for non. I mean, Hep B is an STI, but it doesn't always get included in the STI panel. And then for HIV, similar to Hep C, before you're able to start preventive treatment for HIV or direct antiviral treatment, or sorry, antiretroviral treatment for HIV, you're also supposed to start a Hep B, get a Hep B screen. Uh, there have been proposed changes to NIH indirect cost and how those are reimbursed. That would very much upend first level sort of scientific research that we've been opposed to. We've been opposed to the removal of the ACIP members. We have been opposed to HR1, which is this reconciliation bill that will remove folks from health insurance. Adam covered that quite a bit. Recently, we have been very vocal about our opposition to the ACIP birth dose changes and the impacts that would have. And now, currently, we are in support of restoring federal funding. Adams mentioned that the current shutdown has pretty significant impacts. I will say, even for us at the Hep B United Coalition, we are unable to distribute some of our funds because we don't have access to our program officers at CDC.